Chapter 13, Problems with Childhood. There are various theories that help explain growing up and childhood development. One is Freud's psychosexual development. In this theory, he states that individuals grow and develop by taming their primitive, libidinal, sexual-seeking, pleasure-seeking energies as they move through the stages of childhood. Piaget talks about intellectual or cognitive development, and for Piaget, he states that growth is the ability to organize and integrate experiences. Erikson has the psychosocial development. For Erikson, each person has a task or a problem that must be resolved before they can successfully move on to the next stage in development. Development is the result of growth, learning, and the ability to combine the two. Development proceeds from simple to complex, from gross to fine, and from large to small. Social and emotional development also move from simple to complex. Younger children have simpler emotions and communication abilities. The process of development includes sensitive periods. These are certain times in which children are more affected by the influences within their environment. Developmental periods can be defined as the prenatal period, which is from conception to birth. This is a rapid growth rate, and the total dependency on this is one of the most crucial periods in the development process. Adequate prenatal care is extremely important for a healthy child. The infancy period is birth to 12 months. During this period, it's one of rapid motor, cognitive, as well as social development. Through the bonding with the parent, the infant establishes a basic trust in the world and then a foundation for the future of their interpersonal relationships. The crucial first month of life is filled with major physical adjustments to the infant's life outside of the womb and the psychological adjustment of the parents. The neonatal period is considered the time between birth to 28 days. Infancy is considered 1 to approximately 12 months. The early childhood is 1 to 6 years. In this period, the child attains the upright locomotion until they can enter school. It is characterized by a lot of activity as well as discovery. It is a time of physical and personality development. The motor development should advance steadily. Children acquire language and social relationships. They learn role standards, gain self-control. They develop increasing awareness of dependence and independence, and they begin to develop their own self-concept. The toddler period is 1 year to 3 years, and the preschool period is 3 years to 6 years. In middle childhood, this is defined as 6 years to 10 years. This is called the school age frequently. This period is one where the child is directed away from the family and centered in a bigger world of peer relationships. During this time, there is great advancement in physical, mental, and social development with emphasis on learning skill competencies. Social cooperation and moral development, these become more important. This is a critical period in the development of the self-concept as peers and teachers' evaluations become part of the child's self-assessment. Later childhood is 10 to 19 years. This period is a time of rapid maturation and change that is known as adolescence. This is considered to be a transitional period that begins at the onset of puberty and extends to the point of entry into the adult world. The individual's biological and personality maturing are accompanied by physical and emotional changes. And there is a redefining of self-concept. In the late adolescent period, the individual begins to internalize all the previously learned values and begins to focus on their actual individual identity. This period begins at 10 years to 13 years, and this is called the pre-pubertal period. The adolescent period is 13 years to approximately 19 years of age. In Erikson's stages for childhood development, the first one for Erikson is trust versus mistrust. This is in the infancy stage. This occurs during from birth to 1 year. This is where the individual actually learns to trust other individuals. The autonomy versus shame and doubt stage is in the early childhood. This is 1 to 3 years old. One of the main tasks for this period is becoming toilet trained. The preschool years are defined as initiative versus guilt. This is 3 to 6 years of age. Industry versus inferiority is the next stage. This is during school age of 6 to 12 years of age. In this period, the child begins to become industrious in school, and they want to maintain good grades, and they're very interested in learning. The puberty period is from 12 years to 18 years. This is called identity versus role confusion. During this period, the individual seeks to gain their own understanding of themselves. When looking at colic, the interventions are designed to assist both the parents and the child for calming measures. As a nurse, we help teach the parents to manage colic by assisting them to learn about normal characteristics of crying and how to recognize the infant's cues. By changing feeding procedures and allowing adequate time for burping and cuddling, this will often help the symptoms of colic. There are other various measures that can be used. One would be to create a quiet and a restful environment. There could be aromatherapy using lavender, and the parents need to avoid overhandling the infant. Massage can soothe, relax, and calm some infants during colic. The majority of children outgrow the colic behavior by 5 months, but the parents will still need a lot of emotional support and encouragement during this very stressful time. Infants may not feed if their experience with feeding is not satisfying. Young children may refuse to eat if they've had an unpleasant experience with food, or they may be engaged with a conflict with the parents. During this, there can also be some physical problems that would cause an issue with eating. Maybe it might be poor oral motor control or swallowing issues. This would be one cause of potential unpleasant experience with food. Children that suffer from depression will often refuse to eat, and the adolescent during this feeding may engage in a self-destructive behavior like anorexia or bulimia. For sleep, every individual, their characteristics are different. The child's sleeping characteristics need to be assessed, and the parents' expectations and fears need to be addressed by the nurse. Once the assessment is complete, the treatment to assist in sleep is then designed to assist the parents and the child in establishing a restful sleep pattern. And by the parents following a bedtime ritual, such as maybe reading a book or decreasing the amount of television viewing late in the evening, this is found to be very helpful. When children are attempting to understand and master their environment, they may become frustrated when they're unable to achieve control. Temper tantrums are the result of this loss of control. Many children feel a blow to their self-image and self-esteem, and some children can become quite upset. Temper tantrums routinely become a problem when the child uses them to express more emotions than just frustrations, or they occur frequently, and that can disturb the family functioning. The parents in this environment with the child need to remain calm during the temper tantrum. There are various interventions that can be used with temper tantrums. First, we try to help prevent the tantrum. So, as a parent, the home environment needs to be child-proofed. That way, anything that the child is not allowed to touch will be removed out of their reach. By having fewer restrictions, this can help lessen the chance for conflict with the child. Presenting the child with options, allowing the child to choose within specific limits. This will allow the child to start practicing autonomy and master skills. When the tantrum begins, or in the middle of the tantrum, the frustration can increase. So the parents are taught to use distraction and focus the child's attention on calmer activities and reward positive behaviors. The child needs protection during the temper tantrum because we don't want them to harm themselves or others. The child should not be abandoned during the temper tantrum. The parent should remain close, but should not actually be in their space. One other method would be for the parent to point out to the child that they are getting out of control. The parent should not react negatively or try to discipline the child during this time, and the child should be praised when they regain their control. As a parent, they should only fight battles that they can win. Conflicts that serve no purpose should be avoided by the parents. Yet we do not want the parents to give in to the demands that has led to the temper tantrum. After the temper tantrum, the parents should not hold a grudge against the child and recognize that the child probably feels worse than the parents do. The child needs praise for gaining control, and the parents should keep reinforcing and praising desired behaviors, and they should not overreact to the undesired behaviors. Many mental and emotional problems that are diagnosed in adulthood actually begin during the experiences of the individual's childhood. As a nurse, we play an important role for recognizing and treating the child's mental health problems, because we understand without love and assistance, children may be doomed to an adulthood of failure. Mental health problems in childhood evolve from a variety of situations. If there are environmental problems for the child, such as poverty, homelessness, maybe child abuse, neglect, or violence. If there are problems with the parent-child interactions, maybe the parent is dysfunctional, or there could be a parent-child conflict. Emotional problems for the child often may include anxiety, depression, somatoform disorders, post-traumatic stress disorders. There can be behavioral problems such as attention deficit or hyperactivity disorder, disruptive behaviors, antisocial disorders, oppositional defiant disorders. There may be eating or elimination problems like anorexia, bulimia, enuresis, or encopresis. There may be developmental problems that are happening. There may be an intellectual disability, a learning disorder, or a communication disorder. There can also be pervasive developmental disorders, considering autism, childhood disintegrative disorder, or schizophrenia. According to the United States Census Bureau, 1 child out of 5 lives in poverty, compared to 1 adult out of 8. Growing up is a difficult time for children who are poor, homeless, abused, or neglected. Problems associated with the environment can have a very strong impact on the individual's mental health. Homelessness is a lack of permanent residence. This affects a child in many ways. Many studies have revealed that homeless children have high infant mortality rates, twice the normal incidence of illness and disease, as well as elevated lead levels in their blood. These children will also experience hunger, behavioral problems, developmental delays, speech delays, sleep disorders, immature motor actions, short attention spans, withdrawal, aggression, inappropriate social interactions, and immature peer interactions. Victimization is the process of causing an individual harm. Abuse is defined as causing harm to or mistreating another. Neglect is not meeting a child's basic needs for food, clothing, shelter, love, and belonging. Physical abuse is commonly associated with burns, bruises, fractures, head or abdominal injuries. Sexually abused children have been violated with inappropriate sexual activities. Emotional or psychological abuse, this can take away from a child's self-esteem through rejection, criticism, isolation, or even terrorism. Children that suffer from neglect, which is the failure to provide for their physical, emotional, and medical needs, have various problems. Childhood abuse and neglect both have long-term effects. Children need consistent guidance and unconditional acceptance. Relationships with their parents serve as a test for learning right from wrong and discovering which behaviors will result in a reward or punishment. Parents that set limits and enforce these limits consistently provide stability for children to test the limits in healthy manners. Conflicts between children and parents will occur and can take on the form of verbal arguments or power struggles. When a parent is unable to meet the needs of a child, there becomes a disturbance in the parent-child interaction. The parent is often someone who has had difficult times in their own past with personal relationships, psychiatric disorders, or behavioral problems. The signs and symptoms seen in the child that suggest that there is caregiver dysfunction may include feeding and sleeping problems, delays in development, failure to thrive, signs of abuse or inadequate physical care, and frequent visits to the physician. Emotional problems can range from mild anxiety to severe depression and suicide. These occur in children when they cannot successfully cope with their situations. Anxiety is a vague and uneasy feeling that occurs for them in a response to threat. Most children experience fear and anxiety as part of growing up. One of the more frequent anxieties of infants and toddlers is separation anxiety, which is a fear of being removed or apart from their parents. School refusal can cause anxiety or fear about leaving home, fear of being ridiculed or embarrassed at school, or a concern about some aspect of school. For the main goals for school refusal are to help the child identify with the source of anxiety. If a child is prescribed an antidepressant, the nurse should teach the child and the family to drink plenty of fluids, especially water, eat foods that are high in fiber to help prevent constipation, to exercise regularly. This will also prevent constipation, and to ensure that the child is safe because they may experience dizziness from the medication. Mood disorders are increasing in children. It is found that children who have one or more depressed parents are more likely to become depressed themselves. Depression is seen more frequently as children grow older, and it occurs equally in boys and girls. Children with depression may exhibit different symptoms than adults with depression. School-age children may act out their depression by becoming disruptive or failing. Older children and adolescents may become withdrawn. They may not verbalize feelings of hopelessness or sadness. They may not always act sad, and this often leads adults to think that mood changes are temporary. With the somatoform disorder, the child does not take on the signs or symptoms consciously, but they truly feel ill. Children will often complain of headaches, upset stomachs, or pain. Somatic symptoms are common in school-age children. These are thought to be an expression of stress, anxiety, or some underlying conflict. When children are repeatedly exposed or participate in acts of violence, their psyches take steps to emotionally protect them. The child may feel intense hopelessness, fear, and horror. In younger children, these behaviors may become agitated and disorganized. Often the past is relived through playing out of events related to trauma. Somatic complaints of an upset stomach or other discomforts may happen. Young children often engage in violent behavior, but this behavior is often dismissed as a phase that a child may be going through. Violent behavior in a child at any age always needs to be taken seriously. Children can engage in a variety of aggressive behaviors, from explosive temper tantrums to bullying to cruelty and destruction of property. Bullying is a repeated use of aggressive behaviors to intentionally intimidate someone else. This is very common in schools today. Children that bully others often behave aggressively. They will have strong self-esteem and the little ability to relate to others' emotions. Bullies are known to use violence, manipulation, and intimidation to achieve control. There are various warning signs of violence. The loss of temper on a daily basis, frequent physical fighting, vandalism or property destruction, carrying a weapon, the announcement to hurt or plans to hurt others, use of drugs and or alcohol, the enjoyment of hurting animals, the engagement in risk-taking behaviors, and detailed plans to commit acts of violence. By the age of 5, more than 50% of children regularly interact with a computer or some electronic device. Studies are showing that increased and unsupervised exposure to media may result in hyperactivity disorders, stress, anxiety, eating disorders, as well as impulsive control disorders. Children that are exposed to media violence tend to behave more aggressively. Attention spans are decreasing because of the fast-paced media, and physical and social activities are decreased in children when they spend more time with technology and in the digital world. ADHD is now the most commonly diagnosed mental health disorder in children. Attention deficit hyperactivity disorder is a disturbance that lasts at least 6 months, during which 8 of the following signs or symptoms are present. Child may often fidget with hands or feet or squirms in the seat. They may have difficulty remaining seated when required to do so. They're easily distractible by outside stimulus. May have difficulty waiting their turn in games or in groups. They will often blurt out an answer to questions before they have been completed. They will have difficulty following through on instructions. They will have difficulty sustaining attention during different tasks or play. They will often shift from one uncompleted activity to another. They may have difficulty playing quietly, talk excessively, disrupt or intrude on others. They may not seem to listen to what is being said. They can lose things for tasks or activities at school or home. They may engage in physically dangerous activities. Routinely, the onset for ADHD is before 7 years of age. If the above criteria is not met, then it is not a pervasive developmental disorder. Children that come from broken homes and backgrounds of violence, drug abuse, alcoholism, poverty, and lack of consistency may have behavior problems. The long-term outlook for these children with conduct disorders is really poor if the problems are present before the child is 10 years old, or the adults within the environment engage in any antisocial behaviors. Routinely or nearly half of these children grow up to be antisocial adults or have conduct disorders in adulthood. These children may blame others for their misbehaviors and continually test the limits by arguing, ignoring, or becoming more aggressive. One of the most common childhood mental health problems that relates to eating are feeding disorders, pica, anorexia nervosa, and bulimia. Disorders of elimination may include encopresis and enuresis. Eating disorders are often encountered in adolescence, but young children may also use food to inappropriately cope with their emotions. Anorexia nervosa is a severe disturbance in eating behavior that results in a body weight much lower than the ideal for the individual. Bulimia is the uncontrolled ingestion of large amounts of food, followed by various methods to prevent weight gain. Feeding and eating disorders of infancy and early childhood describe children who routinely fail to eat adequately, even though food is readily available, but the child will not eat. Weight problems or failure to gain weight for 1 month in a child with no GI problems is the most significant sign. Most feeding disorders occur in children under 1 year of age, but they can also be seen in 2 to 3-year-olds. Long-term complications for failure to eat or weight loss are malnutrition and delays in development. Some infants may have difficulty regulating their nervous systems, and this will result in altered periods of alertness. Other factors that are associated with feeding disorders are parental mental health problems, abuse, and neglect. Pica, this is where infants and young children will eat paint, hair, string, plaster, or cloth. Older children may eat sand, pebbles, insects, animal droppings, or leaves. Adults may consume clay, soil, or laundry starch. Rumination is most often seen in infants from 3 to 12 months, but it may occur in older children or adults that have intellectual disabilities. Primary nocturnal enuresis is common in children. It occurs 3 times more frequently in boys and often will disappear without any intervention. Diurnal enuresis is less common and is usually seen in shy children or children that have ADHD. Secondary enuresis will develop when a bladder-trained child becomes incontinent. This will usually follow a stressful event such as admittance to the hospital, birth of a sibling, or a divorce. Encopresis will affect boys 4 times more frequently than girls and is rarely seen in adolescents. The treatment for this focuses on establishing a routine bowel care program. The children need to be praised for the continent periods, and they need to assume responsibility for cleaning the soiled clothing that is often seen to be effective. The American Psychiatric Association now identifies the condition with the diagnosis of intellectual developmental disorder. This diagnosis is a large label and is applied often in haste. For a child to be considered as retarded, they must have problems in general, intellectual, and adaptive functioning. The degree of intellectual functioning is established by the treatment team, and the team will likely include a speech pathologist, a physical therapist, an occupational therapist, the dietitian, and a nurse. There are various degrees. Mild is often in 85% of the incidents. These individuals are still able to develop social and communication skills. They have academic skills to the 6th grade level. They are able to provide self-support. They may need some supervision and guidance, but they are able to successfully live in the society. Moderate occurs in 10% of the incidents. These individuals still develop communication skills. They have an academic skill level to the 2nd grade. These individuals will do well with vocational training, and they can attend to their own activities of daily living with supervision. They can often work in a shelter setting or a community with supervision, and they adapt well to the community life. For severe developmental problems, it is 3 to 4% of the incidents. These individuals may learn to talk and do some basic self-care skills. They can learn survival words such as stop, bus, or police. They are able to perform simple tasks with close supervision, and they can adapt to life within a family or a group home. Profound developmental problems are 2% of the incidents. These individuals exhibit associated neurological conditions such as delays in development. They will have impaired sensory motor function. They are unable to care for themselves independently. They may improve in a highly structured environment, but they will always require some sheltered environment that has close supervision. Fetal alcohol syndrome is the leading known cause of intellectual disability in children. Other causes will include inborn errors of the metabolism, Down syndrome, shaken baby syndrome, extremely high fevers, hormonal imbalances, poisonings, falls, or accidents. A learning disorder is diagnosed when a child with normal intelligence routine falls below the results of other children in the same age group as well as grade on a standard reading, math, or written tests. Learning disorders may affect the child's thinking, reading, writing, calculation, spelling, and learning abilities. Many children in the United States school systems have learning disabilities. Oftentimes, learning disabilities are seen in children with ADHD. Other children with learning disabilities are routinely quiet and have low activity levels. They are often frequently overlooked because of their quiet mannerisms, or they are assumed to have an intellectual disability. Most individuals with learning disorders will respond well to special education classes and encouragement. The most common communication disorders are problems with expression, receiving messages, pronunciation of words, and stuttering. Communication disorders may be the result of some neurological or other medical condition. Problems with language usually begin in the child around the age of 3. The child may fail to use expected speech sounds for their age group. They may speak rapidly or slowly. They may have strange rhythms and word use. Or they may have a disturbance in their pattern of speech, like stuttering. Children with developmental problems will struggle for their learning more than other children of the same age and grade group. And they need love, patience, and encouragement routinely. Pervasive is defined as having a tendency to spread throughout. When the word pervasive is applied to mental health, it means that a problem is severe enough to affect several areas of functioning. Children with pervasive developmental disorders will often have difficulty in social interaction skills, communication skills, and learning. Their behavior is definitely different than that from children of the same age and developmental stages. Autism is not a disease, but a syndrome of associated behaviors. This will result from a condition that affects the development of the nervous system, and it can remain with the individual throughout their lifetime. When diagnosed, the child has serious problems with social interaction, communication, and use of imagination, as well as demonstrates a marked restricted scope of activities and interests. One outstanding feature of autism is its different behaviors. Autistic children will tend to use people in their environment like objects. The children are unable to imitate others or make social contact. Some additional characteristics of autistic disorders may include abnormal speech and communication, abnormal play, the preoccupation with specific objects or routines, restricted body movements, and a narrow range of interests. Rett syndrome is the development of motor, language, and social problems, as well as the loss of previous skills. This can occur between 5 months and 4 years of age. The head growth will decline, hand movements will resemble hand wringing, and there will be a loss of social and severe speech impairments. Childhood disintegrative disorder. This is a period of severe regression in many areas after the child has 2 years of routine normal development. Both Rett syndrome and childhood disintegrative disorder appear after a time of normal functioning, whereas autism and Asperger's syndrome appear during the individual's infancy. Schizophrenia is a condition that is associated with disturbing thought patterns and a distorted reality. Research has shown that schizophrenic children may have attention and memory problems that will interfere with their ability to carry information into the short-term or the working memory. The core disturbance will lie in a lack of contact with reality, and the child will retreat into their own world. Some common behaviors will include bizarre movements, alternating periods of hypo and hyperactivity, inappropriate emotions, language, and use of the body, distorted sense of time, treating self and others as non-human, compulsions, phobias, as well as temper tantrums. Therapeutic interventions for children with mental health problems are first directed toward early identification as well as treatment. The child needs the basic needs to be met, and this can range from gentle reminders to providing total personal care. Many children that have mental health problems have a special need to be nurtured, and the parent may be the only person available to provide those needs. The care provider should find creative ways to encourage the young individual to grow and expand on their ability to function. Even the most profoundly delayed or troubled child will achieve something if they are given the opportunity, the instruction, and the support to thrive and grow.